Good evening, everyone. My name is Dr. Felicia Sussman, and it's my absolute pleasure to welcome you back to our webinar series brought to you by Weill Cornell Medicine, which is part of New York Presbyterian Hospital. And this webinar series is brought to you by the Digest program, which stands for Dedicated Integrated Gastroesophageal Treatment. We are a highly integrated program that works with so many specialists to try to manage complicated conditions. This evening, I have the pleasure of bringing together a panel of absolute experts who are going to talk to us about conditions that are really popular and really concerning to so many patients. And these involve the female pelvic floor. So, for this evening, we're going to be discussing conditions and concerns related to urinary and fecal incontinence. And I am so happy to be able to introduce our panel. The first person I want to introduce is one of my partners, that is Dr. Aditya Ashok, who is an assistant professor of medicine in the Division of Gastroenterology, and he is an absolute expert on all things related to motility involving both the esophagus as well as the lower GI tract. Thank you so much for joining us, Dr. Ashok. Second, I'd like to invite to the panel Dr. Inseo. She is an associate professor of urology, and she is going to highlight for us so many of the issues that are related to urinary incontinence and the different things that we could do for our patients to actually both diagnose it and manage it. And last but not least is Dr. Jacqueline Bondner. She is a assistant professor, excuse me, an associate professor of medicine as well, and she is the medical director of the Women's Health Rehabilitation Program at Weill Cornell, and she's going to actually help us throughout the continuum of the care of these patients because she is so essential in order to be able to both diagnose and also do treatment. Thank you so much, expert panel, for joining me tonight. So, without further ado, we're going to move on. This is a disclosure statement that we like to show every time that we present anything to any patients or to physicians. So, for our agenda this evening, we are going to accomplish many different things. We are going to understand how common are these conditions. We're going to define it for you so that you clearly understand what are they. We're going to then show you how do we do the evaluation, and then we're going to try to tackle some of the treatments that are involved in the management of this patient population. So, how common are these conditions? Well, I personally think they're really very, very common. I see these conditions quite often in women, but I really want to turn to my expert panel. Tell us, like, how common? So, I'd start with you, Dr. Inseo. How common are these conditions? I mean, how often are you seeing this? Clearly, you're seeing this a lot in practice, but what in the general population? What is this like in the general population?
Yeah, I mean, I think the first thing I want to do is kind of demystify urinary leakage and urinary incontinence because I think so many times my patients tell me that they don't talk about it because they don't think anybody else has it. And then once these symptoms start happening, they mention it to one friend and she says, "Oh, I have it." And then they mention it to another and she's like, "Oh, I have it too." So it is quite common. About 50 to 55% of women have some type of urinary leakage. And we know that this happens more often. The older we get, the more likely we are to have these problems with urinary leakage.
So, I
Uh,
mean, go on. I'm so
no,
sorry.
no, go ahead.
I agree with you. I think one of the things that, and I love the word demystify, and I think almost normalize in some things, right? You
Absolutely.
know, what I feel in my practice is we don't know how to help you unless you tell us what's going on. And so many patients, I think, suffer in silence with both of these conditions, whether they be urinary or fecal incontinence. And, there are patients who come to me, they've had a decade,
Yeah.
at least more, multiple decades, where they basically are, I think, ashamed of actually talking about this. Sometimes their spouses, their best friends, their partners don't even know that they're actually dealing with this. Dr. Bonner, is that something that you've actually seen as well?
I mean, I think that most people just, and I think that the other part of it is that a lot of people just assume it's supposed to happen too. I mean, they don't realize that it doesn't have to happen. Oh, I had three babies. Oh, I had two babies. I have one baby, whatever it might be. And I think that a lot of women assume that it's okay to have it and they're supposed to have it. So they don't report it and they don't talk about it. And they don't, and if they do, it's often not to their doctor, it's to their friends. And so, and they get the same loop of, okay, well, we all have it, so I guess it's normal. And so I think kind of putting information out there about how it doesn't have to happen, it doesn't have to be the case, and it's not normal, are things to make everyone aware of.
Mhm, I
Yeah,
agree.
and I think
Go ahead.
sorry. I think the flip side to what Dr. Bonder is saying is that because a lot of my patients think it's normal or expected, they also don't think there's anything to be done about it. So they think, well, why am I going to go tell someone if it's just something that's supposed to be happen to me? It's supposed to happen to me. It's just part of getting older. It's a part of having babies. I'll just live with it, and I'm not going to tell anybody because I don't think there's anything that could be done about it anyway.
Yeah, I agree. One of the things that I'm sure a lot of people in the audience hear a lot is that's just part of getting older. That's part of getting older. And you know, the truth is, there is a lot of things that start to come out as we age. There's no doubt about it. But just because something might start to happen as we get older, just as you're saying, Dr. Nzeo, it doesn't mean that we do not have therapies for them. It might be part of some of the aging process, perhaps, but there's always hope. But you need to bring it to us. So I think that that's obviously a very, very important part of this, to start this conversation. So now let's get back to this like urinary leakage, this urinary incontinence. Could you explain to us, Dr. Nseo, what does this mean? Like, what is actually happening? When someone is having this occur to them, there's different types. Could you, sort of further demystify that for us?
Absolutely. So I think, I love what I do because oftentimes patients will come to me with complaints that are pretty general. It's not uncommon for someone to come into my office, they sit down, they say, Dr. Say, I'm leaking all the time. And it's my job to help kind of try and piece together certain clues about what they're telling me to kind of figure out what type of leakage that they have, because the type of leakage they have, the type of urinary leakage they have, will let me determine what type of treatment will be best for them. So when we're talking about urinary leakage, anytime you're peeing on yourself when you don't want to, we call that urinary leakage or urinary incontinence. There are three main types. And like I said, the type kind of determines how we treat it. When we talk about the big categories in terms of why my patients are often leaking, we talk about stress incontinence or urge incontinence. Stress incontinence, I think, is sometimes poorly named because when patients hear stress, they think, oh, is this what happens when I'm stressed out? But actually, when we're talking about stress, we're talking about pressure on the pelvic floor and the pelvic floor muscles. And so when there's leakage that happens when there's pressure on the pelvic floor, commonly you're thinking about the leakage that happens when you're coughing, laughing, sneezing, jumping, bending over, running. That's what we call stress incontinence because of the stress it places on your pelvic floor. And then urge incontinence is the type of leakage that's happening when you're doing the pee pee dance. It's when you feel like you really got to go and you feel like you're rushing to the restroom and you can't make it in time. That's what we call urge incontinence. And that's happening because the bladder is having a contraction or a spasm before it's supposed to, before you're actually supposed to go to the bathroom. And typically what should happen is that when your bladder is full, it sends a message to the brain to say, "Hey, I'm full," and then the brain will send a message back to the bladder to say, oh, this is or isn't a good time for you to go to the bathroom. And when someone has urgent incontinence, it often goes hand in hand with overactive bladder, where that bladder is sending signals and acting pretty much on its own. Um, And then mixed incontinence is when we see patients have both types of leakage.
So, first of all, one of the things that I love that you're doing is that you're actually even saying like common words like pee, urine, all these things, I think also patients, when we talk about things like this, it's already embarrassing, right?
Yeah.
And what I like to do is just, these are words. These are, that these are fluids that we pass. You could use whatever words, you want that's describing that, the common words that you feel comfortable actually using as well. But I think the main thing that I'm hearing from you, Dr. Inseo, is it is not supposed to be happening, right?
Correct.
I mean, this
Absolutely.
is just an involuntary thing that is not supposed to be happening. So, could you just also explain a little bit what allows this not to happen? Like, what are the protective mechanisms in our body that actually make you not have this happen to you that might have now been affected that you have this condition?
Yeah, absolutely. So I think, this is kind of the big umbrella under which all of this whole webinar is about, which is the pelvic floor. And I think the pelvic floor muscles, and I think Dr. Bonder can speak to this as well. The pelvic floor muscles are so important to the normal function of our bladder and our bowels, and really serve an important role in terms of keeping us. And women include the muscles themselves, and then the part of the muscles that stay closed while your bladder is full. And that's what's important to helping you stay dry throughout the day when you're doing activities, etc. And so that's why, we often find that assessing the pelvic floor muscles and assessing the strength of those pelvic floor muscles is so important in terms of determining how they're helping you or not, in this case, helping you to stay dry.
Okay, so this is basically a muscle problem, right? I mean, there are muscles that are meant to protect us, and the reason why they are losing their pee, losing their urine is because those muscles are not functioning normally, and that's part of what the whole workup really is about, right?
Yeah, absolutely. And the pelvic floor muscles are especially important when we talk about stress incontinence, because when those pelvic floor muscles are strong, they're able to support the bladder, and the urethra, the tube that we pee out of, and keep it from kind of essentially staying open when you put extra stress on your pelvic floor. So it's the strength of those muscles that are able to hold the bladder and the urethra in the right place to kind of help everything stay where it should be. And we know that, while urge incontinence, or the type of leakage that happens when you're running to the bathroom, happens because the bladder muscle is having a spasm. We know that the pelvic floor muscles can also help in terms of reinforcing the bladder to kind of calm down and not have those spasms as well.
So, and the interesting thing is it's complicated. It's complicated, it's
Yeah,
not so simple, and that's why it requires being seen by experts to be able to figure out what exactly is going on. So,
absolutely.
so now that we have sort of like a basis of what we're kind of talking about, we always like to in these sessions, we're inviting you into the experience when the doctors are sitting basically in our multidisciplinary meetings talking about a patient. So I'm going to start with our patient for this evening. This is a 58-year-old female with a history of obesity who complains of both urinary leakage and stool leakage for 5 years. She also complains of a fullness in the middle of her belly. These symptoms have caused significant anxiety and embarrassment, and she stopped going out with her friends because of it. She has given birth to 3 children. All children were delivered vaginally. She has had no surgeries, but states she needed stitches with the birth of her last child because of tearing. She drinks 1 cup of coffee per day. She's up to date on her colonoscopy. So, when I look at this history, what's really interesting is, doctors have a way of listening to a history and then seeing certain things that are these really important facts that come out that make them realize that, we're certain keys to the case. So, if we looked at this case, What I'd love, perhaps any of you, maybe Dr. Bonner can just for a moment just pull out some of the things that, and some of them are highlighted here, but that struck you as part of the history that made you say, wow, these are maybe key things that I'm listening to that are starting to tell me some of the clues as to what's going on with this patient.
I think that just hearing the part about her symptoms themselves, what she's most bothered by. So, the urinary leakage and the stool leakage, like Dr. Enseo said, earlier, these are controlled, by some of the same muscles. And so is there something in common between these two symptoms that we can link to one specific thing that might be happening. I think also the fullness in her belly, is that related? Is it not related? I think those are things that we really have to kind of piece out because there's lots of different things that can cause fullness in the belly. And so, like you kind of highlighted, those three things of her biggest symptoms are really the things to sort of start to hone in on and figure out, are they related or are they not? And what do tests to test for each individual one, or do we have to do something to kind of rule out what's going on for all of them at once? I do want to point out also about the significant anxiety and embarrassment, and even the next line that says stop going out with her friends. As a rehab medicine doctor, one of the things that we look for and talk about to patients is, well, like your functional status. How has your life changed because of your symptoms, and what's going on because of your symptoms? And so people don't, we talk to patients about, are they able to get up their stairs? Are they able to, are they able to get up and from a chair? All those things are of course important, but not going out with your friends and not being social or really can start to affect someone's mental health and cause even more anxiety and more embarrassment and more worry. So really kind of, normalizing the fact that, well, I mean, it's not normal to do this, but normalizing that getting this treated and getting evaluated is okay. Going back to the idea that, the woman's probably not talking about it or finally at the doctor because she always assumed it was normal. But, this isn't normal. And especially when it starts to interfere socially or with your functional status and with your regular everyday life, it really needs to be addressed. And that's, true of so much. And so, that is really something that's highlighted to me. And then, of course, we do know that, women who have had children are probably more at risk most of the time for pelvic floor issues, whether it's weakness or any other kinds of problems that from the muscles themselves or from the organs and other things that can kind of contribute to some of these incontinences. So helping to figure out, how much of that is involved. And the fact that she had some tearing with these deliveries also kind of does tell us that she's more at risk for some of this weakness in the muscles. When a woman tears during delivery, it's usually as part of the, you usually tear part of the muscle. And so that tearing is specifically causing a weakness in the muscle that might be interfering with their ability to contract the muscle and to use the muscle. And so it's really important to kind of take that into account.
Yeah. I think one of the things that's very interesting, and, Dr. Ashok, I'd love for you to comment on this. I think it's not common, when you have a 58-year-old, for them to actually even think, or for people to actually even ask them sometimes about their obstetrical history on some things, right? Because they think they gave birth a long time ago. How could this actually be related? Maybe you could even just, sort of comment on that. And I'm sure in your work, that might be something that you really are very interested in understanding. Could you comment a little bit about that and how this all plays a role potentially in some of these conditions?
Yeah, of course. So we know, right, that, the research has showed us that in the immediate postpartum people, many, many, many people experience some form of stool incontinence, right? Some poop is leaking out. That being said, the majority of people also recover, over the course of 6 to 9 months after they've given birth. There's then this window of period where people are often asymptomatic, right? They're not struggling with this issue, and then it comes back. So, traditional, as you astutely pointed out, right? Like a lot of people aren't connecting the two, but it has been shown also that, you know, insults to your pelvic floor, uh, decades before can start to manifest later on. And you can think of it like, these are all like cumulative insults, right? It adds up, it adds up, it adds up, and at a certain point, it gets a little too much for your body to be able to handle. So we see it all the time, and it's really important to take into account a very, very clear obstetric history, right? Because a lot of people, one person's tearing is not another person's tearing, right? We go down to the degrees of laceration, and some of the tears, they can, by definition, go into the anal sphincter, and so that's why we have to really delve and in some cases, really try and get some of these delivery reports too, if we're able to.
Yeah, I mean the same way when you go to the doctor, where we ask you for your past medical history, it's kind of funny because I think many women they're like, "Oh, I had children," but they don't really realize that the pregnancy, the delivery, all those things are actually medical history pieces that really could be profound, I think, when it comes to some of these conditions. So it really seems to me like, this history is leading up. And the other thing I think, Dr. Bonner, that you brought, that was really, I think, actually really poignant is, we really do lots of times want to have one diagnosis, right? I mean, is there one thing that's sort of going on? Are there, because sometimes people wind up running around to a whole bunch of different physicians about things. And some of the goal of multidisciplinary care is recognizing even if different organs may be affected, there might be some continuity, even in the care process, that might actually make all the symptoms better. And so I think that that was actually something, that really is important to bring out as well. So, Dr. Ashok, one of the things that we might want to do as part of the workup could be some imaging. So when you heard about this case, what were you thinking might be the next step to try to decipher what's actually going on?
Yeah. So in this particular situation, people are not textbooks, right? They come in and they're not necessarily going to say the exact symptom that you might read about if you Googled something. But, particularly in women, things like fullness and bloating, these are all things that oftentimes get, dismissed, but can be they can be manifestations of different pathologies either in the GI tract or in the gynecologic tract. And so I always have a low threshold uh, whenever there's a concern for these types of issues, fullness, bloating, to make sure I'm not missing something really bad, like an ovarian cancer, something really bad, right? So oftentimes I'll get a CT scan, as was obtained in this patient here. And as you can see, right, so this is a CT scan. So just for everybody watching, basically you can think of it like 1,000 x-rays stacked on top of each other, and we're scrolling through the x-rays, so we're able to get essentially slices through the body, and we're scrolling down from the head to the pelvis. And right now you can see essentially all of this is normal looking. That's normal small bowel, that's normal colon, liver looked fine, and you can see the bladder up in front. So this is all very, very reassuring.
Great. So, you have someone, you want to make sure that we're dealing with something that is, it's very troublesome, it's causing significant symptoms, but that they're not in any immediate danger of potentially something like a cancer or who knows what that's going on. So that's the purpose of doing this, imaging of the patient. Okay, great. Um, so then, so now that you have the imaging and you don't see anything terrible, I would love for Dr. Nseo to actually start to take us through what do we do next? Like, how do you think about getting this evaluation, this individual who's losing their urine?
Yeah, absolutely. So as I kind of alluded to earlier, um, and Dr. Ashok also mentioned, patients can't tell us very clearly. They're not oftentimes aren't coming in with their exact diagnosis. They're just going to tell us what they're experiencing, and it's our job to kind of be the detectives and figure out what exactly is going on. And so the most important thing when you're talking about urinary leakage is really the history. I'm probably gonna ask more questions than you've ever been asked about your pee in your life, because I want to figure out how often it's happening, when it does happen, how much there is, what you're doing to deal with it, because that gives me some idea of how severe it is. Does it happen at night or only during the day? And are there certain things that seem to make it worse? Do you find that your leak is worse if you've been really active all day? Is it worse if there are certain things you eat or drink? Is it worse if you have coffee in the morning? Things like that. So that's all going to help me figure out exactly what type of leakage you're having. That's probably where I spent the majority of my time when I'm talking to patients, is really trying to tease out, the history of these symptoms. When did it start? Was there anything in particular that happened around the time? A surgery or something like that. Oftentimes, as we kind of talked about in the beginning, these are symptoms that have been going on for a long time, and by the time someone's gotten to me, it's been happening for a while, and they're usually quite bothered by it.
Mhm. Yeah,
Um,
I think it's also interesting, like you said, they're going to come in, they're going to talk more about this than they ever have. I've One of the things I actually say to patients is when you're going into a doctor, before you go in, think about the sort of what brought you here, like put it together. When did it start? Is there, anything that's changed in your history? What do the symptoms really feel like so that you're able to really articulate this to me in the examination, because that's your opportunity to share it all. Like we want you to overshare, is basically kind of what I, sort of say to them when they're coming in for a visit.
yeah, absolutely. And the things that we've kind of touched upon already there, an important part as part of that history is, of course, your obstetric history, because I'm going to be start. I'm also going to start looking for risk factors. Had prior pregnancies, any prior pelvic surgery, medical conditions that we know that can make urinary leakage worse or make your bladder behave worse, and things like that. So that's definitely going to be, a lot of the digging that I'm doing to start the visit. Um, the
Great. So
other
then,
parts. Oh yeah, go ahead.
and then it seems like it looks like there's a whole list of different testing,
Yeah.
that starts to happen. So I would love for you to also sort of start to kind of like work us through a little bit of this different testing and how it plays a role.
Yeah, absolutely. So, like I said, oftentimes patients are just saying, I'm peeing on myself, I'm wetting myself," and so there are certain tests that we're going to do in the office to help us determine which type of leakage it is. One of these is the cough stress test. It's pretty straightforward. Essentially, all it is we make you cough. We might make you bear down or strain, like you're trying to have a bowel movement, and that's just our way of seeing, do you have what we call stress incontinence or stress leakage, meaning that when you put more pressure on the pelvic floor, urine comes out. This is our test to say, like, oh yeah, you do have stress incontinence, and it's our way in the office of trying to mimic what's happening when you're at home and saying that I'm leaking when I'm, running or sneezing or coughing or bending over. And so we often will try to do it when a patient has a full bladder so that we can really see, as much as we can in the office, what's happening to them when they're at home.
One of the things, and Dr. Ashok, I'm wondering if you actually also experience this. S- Sometimes when I'm, suspicious this is going on with a patient, and they're sort of not telling me yet that they're losing urine or even stool, I actually ask them, "Do you use a panty liner?" And like, because that actually is almost like an easier way to kind of say something like, I actually need something in my undergarments to protect my undergarments. And that kind of opens it up. And I think sometimes people don't even realize that they're losing it because they're using something to protect their underwear. And as a consequence, it's not such a big deal to them, right? You know, they're not realizing, like, because you go into these pharmacies, they're all over the place. There's diapers, there's panty liners. I mean, rows and rows of these things, and that also can make People feel like everybody has this, and this is all I'm supposed to do is just put something into my underwear and, not seek attention. So that's actually one of the things that I ask about, as well.
Yeah, definitely. I do as well. And or put another way, if they say they don't use any liners, I'll oftentimes ask, "Oh, do you notice any staining on when you go to use the restroom?"
Hmm. Yep.
Mm, And that opens it up to sort of for people to really uh divulge a lot of information that people keep to themselves for the most part, right? Really sensitive stuff.
It's understandable. It's very understandable. So okay, so now we're doing that, what seems like a very simple test, right? To be able to just mimic real life situations. So now what about this? What is urethral hypomobility?
Yeah, so that's just a fancy term for us, again, to assess another way for us to assess how much your pelvic floor isn't supporting your bladder and urethra when you're doing these activities that put pressure on the pelvic floor. So this is another part of the exam that we'll do. And oftentimes it's done in combination with the cough stress test, where we're going to be watching the urethra itself, the tube that you pee out of, to see how much it moves when you strain. It's a great shortcut for us to understand, if it's moving a lot, that tells us that the pelvic floor support isn't there like it should be. And that's again another way for us to say, oh, this is a patient that has stress incontinence because when they bear down or strain or something like that, the urethra is moving a lot and means it's not staying closed with those activities, and the urine is likely to come out at that time.
And this is not painful, right, to assess
Not
this?
painful at all. We don't do anything but look. A
Okay.
lot of our exam is just a lot of looking and telling people to cough and strain. So
Okay. Perfect. I
not
mean,
a lot of discomfort associated with it.
because I could tell you, especially as a gastroenterologist, a lot of the fear in going for exams is number one, embarrassment. I mean, absolutely. Sometimes it's the prep of the exam that people just don't even want to think about doing. But the other is they're nervous that things are going to be painful when they're going for exams. So I think just even demystifying when you're going into the office to get these tests done, that they're not painful as well. So I think a lot of people probably heard about, sometimes like even like if they're in the hospital, sometimes after surgery, they hear about post-void residuals and whatnot. That's a test that I know people might have heard about related to urine. What is that about?
Yeah, that's just another, something we didn't touch on as much, but can also happen is that sometimes you'll leak because your bladder doesn't empty well, and it'll just essentially like a pop-off valve. It'll start leaking when it gets too full. And so looking at that post-void residual, looking at how much urine is left after you pee, can give us some more good information in terms of how well your bladder is doing its normal function of emptying, and making sure that there's not something more complex going on with in terms of the urinary leakage.
So should there, just explain this to us. So should there be any urine left in the bladder? Like what's normal?
Yeah, so typically there's always a little bit of urine left. It's not unusual for us to see a post-void residual of like a teaspoon or little less than half a cup of urine. So anything under 100 milliliters that we see, that's reassuring to us. And it's when those numbers get bigger, that we get more concerned about people holding on to extra urine in the bladder.
Okay, excellent, excellent. Okay, so another way to look at this. And then there's this other, what looks like more complicated kind of testing. So, what are urodynamic testing? What
Yeah.
is that looking at?
So this is not, for the straightforward patient coming in the door, they probably will never hear about or have to undergo urodynamic testing. But if we have patients that are a little more complicated, maybe their symptoms just aren't clear from the history they're giving us, they've had prior surgery that's kind of clouding the picture, or we note that they think they're emptying their urine, but when we scan their bladder afterwards, with and find that there's a significant amount of urine left behind, we think, okay, let's do more testing to figure out what's going on. And so that's when we'll do urodynamic testing. That's essentially a test that it's our best way that we have of trying to really figure out what's happening with the bladder. Is it functioning the way it should? Is it able to hold urine without causing you to leak when it's trying to store urine? And then is the bladder working and allowing you to empty your bladder fully, when your bladder becomes full and it's time to urinate? And how is that working hand in hand with the pelvic floor? So. It's a procedure we do in the office. It requires a couple small catheters to try and measure pressures in the bladder and the abdomen. And that's our way of trying to determine whether your bladder is working the way it should.
So how uncomfortable is urodynamic testing?
It is a little uncomfortable because of the catheters that we place. If anything, it's just a weird experience.
Yes.
You're sitting for an extended period of time around a couple people in the room while you're getting your bladder filled, and then we tell you to pee while we watch. So, it's definitely not a normal experience. And
Right.
so, we try our best to try and, make it more comfortable for patients. But that's more than anything, it's just the strangeness of it more than any
Right.
real kind of
Exactly. But the,
discomfort.
the beauty of this is these are professionals who are really interested in watching people urinate and they're very interested in this. So although it seems, sometimes it could seem weird to a patient to have it, but for us, we love doing these exams. This is how we get the most information so that we're able to really specifically get to the root cause. And I would say that that's what this is about, right? Getting to the root cause of what actually is sort of going on with the patient. Okay, so the patient, it's all about the patient, right? So now let's get back to our patient. So she sees a urogynecologist who finds that she has urine leakage on the cough stress test with a bladder volume of about 300 milliliters, and she's found to have increased movement of the urethra during straining. She has a post-void residual volume of about 90 ml. So what are we, I mean, we've gone through all these studies. Dr. Say, you very elegantly explained to us what they are. When you look at these tests, what is it that what's happening with our patient?
Yeah, so, taking all of this information into account, um, to start, she has a bladder volume of about 300, which is an appropriate bladder volume for, a woman of that age, anywhere from 300 to 400. So that tells me that her bladder is probably functioning well. She leaks urine on the cough stress test, and her urethra moves. And so those are two keys that are leading me down the path of thinking about, a patient with stress leakage or stress related incontinence. And then we see that after she urinates, there's only about 90 milliliters in her bladder, which is a completely normal amount. So further reinforcing this idea that her bladder functions well.
Okay, great. Okay, so how would we characterize her urinary issue? So, basically now, the key thing is for us to just get to, excuse me, I went backwards here. The key issue for us is trying to understand, like, what do we think is going on with this woman? So, what do we think is really the problem here?
Yeah, so I think from a diagnosis standpoint, we'd say she has stress urinary incontinence, meaning there's an adequate support of the bladder and the urethra, when she is doing activities or increasing the pressure on her pelvic floor. And that piece of inform that those pieces of information are really helpful when we then start thinking about, what we might want to do to help her.
Excellent, fantastic. Okay, so we believe she has stress urinary incontinence based upon this finding, right? Perfect. Now, she's also having problem with the poop. And so, Dr. Ashok, I would love for you in the same way to tell us how would you now evaluate this fecal incontinence?
Yeah, so first off, I try to always get a sense of like what's actually coming out, right? Because a lot of people just say they're incontinent, but for what comes out of your anus, it does matter, right? Is it mucus? Is it liquid? Is it solid? Some people use the word incontinence to refer to, inadvertent passing of gas as well. So it's really helpful for us to understand what exactly the patient is experiencing. In most situations, we do a physical exam, which involves both an external physical exam as well as a digital rectal exam. We have our chaperones, which is a standard protocol for all of these procedures, or all of these exams, I should say, that match the gender of the patient, just so that everybody is comfortable. And then we have additional testing available too. So we have anal rectal manometry, which we'll get a little bit into and I'll chat with more. We have different types of imaging and testing like balloon expulsion and MRIs. And, there are a lot of different ways that we can evaluate this, but it really just starts with the history and physical.
And Dr. Bonner, could you just tell me when you're sort of looking at these patients, is there anything about the initial workup or the physical that actually you would be particularly interested in?
I think that for these patients with the fecal incontinence and also with the urinary incontinence, my physical exam might vary a little bit from Dr. Ashok and Dr. Ensayo's exams. I really look at the pelvic floor muscles themselves and kind of try to assess the tone of the muscle, kind of similar to any other muscle in the body. Is it toned? Are you able to use it correctly? Can you do a good squeeze of the muscle when you need to? Is it too relaxed, and is it not able to do its job because it's too relaxed? And looking at there's different ways to look at that on the physical exam, by doing a vaginal exam and assessing the muscles, as well as on rectal exam to kind of assess the muscles by putting a finger either in the vagina and then in the rectum and feeling what has happening with the muscles around that area. And what happens is that a lot of times women, we think of Kegels and these kind of strengthening of these muscles and telling a woman to do a Kegel. And the majority of women and men for that matter, but the majority of women don't do a Kegel correctly. They'll start kind of, and I watch them do it either with a finger in the vagina or the rectum, or just ask them to do it without even examining them at the same time. And no one should see you do a Kegel. If you do a Kegel and your butt squeezes or your back clenches or you arch your back or you squeeze your thighs and lift your butt are probably the two things that people will do mostly that as part of a Kegel, and that is not correct. Nothing should move. I say to women that squeeze your muscles as if you're in a quiet room. You don't want to pass gas and you don't want anyone to see you do it. Right? Like no one should know that you're holding. And so that really kind of isolates those muscles. And so right there, if someone's not doing it correctly, you can kind of diagnose a problem with just their ability to do that squeeze and that contraction, which might be contributing to the symptoms. It might not be the only cause of the symptoms, but that's one assessment of pelvic floor muscle, incompetence in terms of not being able to use them correctly. And on the opposite spectrum is that sometimes when I look at the muscles, basically they're too tight. People are doing too many Kegels and doing them correctly and kind of over tight, or have a reason for, kind of that they do it they do it multiple times a day. They do it, with Pilates, they do it with their exercise routine. They do it on the subway. And then all of a sudden their muscles are too tight. And I kind of liken it to somebody. I tell patients that when they're too tight, you can't get that squeeze that you need to hold in urine. And that makes them weak also. So if you think about it, a good way to kind of compare it is that if, I'm a musculoskeletal doctor, right? So this is why I always think about if you were going to pick up a heavy item, a heavy weight, a heavy chair, whatever it is with your biceps muscle, you would never do it with your arm already bent. You straighten your arm and then you lift. Every muscle in our body has an optimal length at which it's the strongest. And so, the pelvic floor is no different and has to be that length too. And so then you want to learn how to strengthen it once it's that optimal length, whether it's too relaxed or too tight. And so you would never pick up a heavy item with your arm already bent because it's already weak in that position. It's the same idea. If the muscles are too tight, then it's already weak. And so those are things that as a rehab doc that I'm often looking for on physical exam, in conjunction with, the patients seeing the gastroenterologist and the urogynecologist to kind of look at other aspects of things. But from an exams perspective, that's often what I'll do from a fecal incontinence and a urinary incontinence standpoint. So, yeah.
Yeah, I mean, I think it's really important to realize that all three of you are looking at the same person and in such different ways. And the other thing I'd like to comment, I am sure that there is never really a time on a webinar where more people are trying to figure out if they know how to do a Kegel exercise, just by the discussion. So, afterwards, we could maybe do a tutorial on how people can do it. But I think it's really interesting what you just said, that there are people who actually, overdo things. I mean, we know a lot of people over exercise as well. So both things can actually, not doing it correctly, overdoing it, all play a big role. So now we have, we're starting our evaluation, and this is another kind of radiology test. And, Dr. Asha, could you talk to us about this special MRI and what is it doing and what are you looking for in it?
Yeah, perfect. So essentially what we're looking for, this is an MRI image. It's really good at looking at like soft tissue and muscles. And what we're really looking for is there some sort of anatomic issue at the end of your GI tract that is causing the issues that you're struggling with, in this case, incontinence. And you can see, some of the stuff is like bright, shiny, like that silver ish towards the back end. Now, what that really is that it's part of this. We give people an enema that's got this liquid that lights up basically for an MRI, and then we have them, simulate a poop while they're getting the MRI. It's a standard thing. It's done in, most medical centers. And it allows us to really get a sense of, is there some anatomic issue? Is there hernia? Is there something like that that's contributing?
Yep. Okay, great. So it's another one of these radiology tests to sort of look at things from a broad perspective. So now this is a very pretty test. What is this about?
Yeah, so this is again another way that we can evaluate like what's the issue. So basically, as Dr. Schnell said, it's a very beautiful test. Essentially, the colors tell us different information about the pressures, and this is all coming from a very small, something like that's like the size of a straw or smaller, probe that goes into your anus. And we have patients do exercises, not exercises like they're getting on a Peloton. They're on their side, and we ask them, okay, squeeze the squeeze the probe, push the probe out, push the probe out. That's the extent of it. And we know, based on the information we're getting, okay, this person's generating enough pressure to be able to have a bowel movement, and their sphincters are appropriately relaxing. But it helps us get a sense because you may not be generating enough pressure. You may not be squeezing the toothpaste bottle well enough. Um, but you may also be squeezing it just fine, but you're not taking off the cap, right? It's not relaxing, as Dr. Bonder was getting to. Or, in some cases, as Dr. Bonder was also alluding to with, people who overexercise, you may be tightening the cap on the toothpick bottle when you're squeezing. So all of these things, this is basically the test that gives us that information.
Does this hurt at all when you do this?
No, people do not need anesthesia. It, it's it feels uh honestly, the most people describe it when they have it is, if anything, feels like maybe they have to have a little bit of a bowel movement.
Okay, excellent. And this is done in the office setting.
Yes, done in the office setting, no sedation required, no special prep. You go home that same day, nothing, no issue like that.
Great. Lots of information and not a lot that actually happens. So now, plot thickens, additional testing, a abnormal balloon expulsion test. What happened here? What's this?
Yeah, so this is something really, I think really excited that we're doing at Cornell, which is not done everywhere, but we're able to offer it at Cornell, where essentially what we're doing is we're inflating a balloon. Now, this is not a huge balloon. We're putting about 40 milliliters of fluid or air, right? So a very small amount into the balloon once it's in the rectum, and asking people to essentially try to poop it out, right? And we have certain metrics that we go for, but this really gives us a sense functionally if what we see on all the other tests that we do, if it matters, right? Because you can find a bunch of abnormalities, But is it clinically significant to someone? Is it actually interfering with their ability to defecate? That's where this comes in. So in this patient, they had an abnormal balloon expulsion test, which tells us they're not able to basically pass stool well.
Wow. Okay, so just inflating this a simple balloon and then doing this special measurements lets you understand that they are actually not able to move stool out of their rectum in a normal way.
Yeah, and it's all done in a very discreet way. We have a bathroom that's attached to the room where we do this procedures, so there's no walking around outside or anything like that. You are just, in your private bathroom doing this test, and we stand on the outside, we instruct you, and it's very, very private and very easily done.
Excellent. So how should we, characterize her stooling? Like, how would you go about talking? So this is, obviously a complicated looking term.
Mhm.
And, Dr. Ashok, what is it based upon the workup that we've done? What is her, diagnosis?
Totally. So very complicated, Karen. With a lot of S's where it doesn't seem like you need as many. Dyssynergic defecation, all it means is in her situation, right? The anorectal manometry, that color plot that we saw, it was showing that that the sphincter was contracting, your anal sphincter, when it should have been relaxing, right? Paradoxical contraction. And then we confirmed it with an abnormal balloon expulsion. So taking those two things together, we get the diagnosis of dyssynergic defecation. And really, all that means is that the machinery that helps you poop is not working well.
Okay, excellent. So, let's take all this, fabulous testing that we've done, go back to our patient. So, all of you, I'd love you to sort of comment on how do we manage her? Because in the end, you've now done all this testing. We've clearly found abnormalities in both the way that she is able to hold urine, as well as the way that she's able to manage stool. So, I'd love to hear from all of you in terms of, what was done to try to actually help our patient, because it seems like there was a lot that we were able to do. So maybe Dr. Bonner, why don't you start with in terms of like the pelvic floor physical therapy and biofeedback?
So pelvic floor physical therapy is physical therapy that's done by a highly trained therapist who has undergone extra training beyond school to work with these patients in terms of often in a private room, and basically to help retrain the muscles. That's exactly, what they do is kind of help decrease the tone of the muscles if they are tight, and then also help by teaching patients how to use those muscles correctly. Biofeedback there's many different types of biofeedback. Often, a lot of the studies are done in biofeedback are uh, using a certain type of tool where basically similar to the manometry testing where you kind of or even the urodynamic testing where you're using something called EMG to kind of see what the muscles are doing and how much the muscles are moving when you kind of do a contraction, and then having the patients visualize what they're doing and kind of seeing lines go up and down and kind of using that line go up and down. If you see the line go up, but you want it to go down, you can try to teach the patient to kind of make the line go down and kind of use that visual stimuli. But there are other ways to do it besides that recording. That you could do it with just someone's finger and seeing it move. There are also training tools that you can kind of put in the vagina that kind of are similar to almost look like a tampon and have a big extender at the end and have a big piece coming out, and basically when it moves it means that you're contracting. And so it's just biofeedback is really a tool that can be used to kind of help retrain those muscles, either to get them to relax more and then learn how to strengthen them, or just strengthen them and get them to be able to contract better. And so you can use that both rectally and vaginally for the urinary incontinence and the fecal incontinence. And so a lot of physical therapists will kind of spend time educating patients on the pelvic floor, how it moves, how you use it, and then kind of progress to this type of work. Often there is internal work that is done by the therapists, and basically Uh, if someone has tight muscles to begin with, they can often do certain types of releases of those muscles to get them to be less tight, and then learn how to strengthen. And same is true, for the rectal muscles as well. So that's a kind of quick overview of it. It's not always the quickest thing to heal. It takes time to relearn these exercises. And then, of course, it becomes important to incorporate them into your functional daily life, right? So with stress incontinence, yes, you might be able to do a Kegel and hold it for a long enough period of time, or lying on your back where there's no gravity. But once you start to stand up and gravity plays a role, or you're exercising, or you cough or sneeze and there's even more pressure, you have to work up to that strength, similar to using weights at the gym, right? Like if you do using a 2 pound weight, it's going to be much easier than a 10 pound weight. And so basically kind of working up to kind of more functional positions is how the physical therapist will often uh, kind of continue with therapy to advance people. So to try to get them to be able to do those Kegels or do those strengthening exercises while running, while jumping, while coughing, while sneezing, and so forth.
Great. And so it seems like it's something that's dedicated, ongoing, maybe a little bit of prolonged type of physical therapy. But if you're dedicated to it, can try to really help improvement. So, Dr. Ashok, tell me about psyllium husk. Like, how does this play a role in what's going on?
Yeah, so everybody under the sun has heard about fiber supplementation in some form or another, right? You go into the pharmacy, it's the orange and green containers. Psyllium husk, it's a plant derivative. It is the fiber for which there's the most evidence for in terms of it working. And specifically, it basically, you can think of it like uh, bringing stool to the ideal form, right? It takes loose stool and makes it a little firmer, and takes really firm stool and makes it a little bit looser, and acts like a scaffolding for the stool itself. So we use it to optimize stool consistency, so that we can get people feeling better. It's worth noting that, this is changing this consistency of stool. So it's not something you can take as needed. It needs to be taken consistently every day. And we see changes at around the 2 week mark. So we do need to monitor people.
So after the diagnosis, we're using a fiber supplement. We're getting physical therapy to the pelvic floor from an expert that helps guide us through this. And with just those two interventions, her incontinence improves. She has reduced anxiety and stress, and also notes that that abdominal pain that she was having also, sort of improves. So, with our last slide here, it sounds like these two things were really interconnected. So, Dr. Inseo, just are these interconnected, these two things? Like it's just because these organs are near each other, things like that? Is that what we're talking about?
Yeah, absolutely. So I think, um, you know, I love that aha moment when patients realize that their some of their conditions are connected or related to each other. A lot of it has to do, as Dr. Bonner and Dr. Ashek kind of mentioned, has to do with the pelvic floor and how the pelvic floor muscles control, both your stool and helping you not leak stool, and then also helping you not leak urine as well. And so having control over that pelvic floor, those pelvic floor muscles are really important for that. And then, I always tell my patients how close everything is in the pelvis. When you have anything happen with your bowels, the bladder's right nearby, and it's like having like a noisy neighbor with a house party. They're gonna bother you, they're gonna keep you awake, and they're gonna cause your bladder symptoms to happen as well. So I think, this slide really kind of encompasses why I think, a webinar like this is so important to really, help understand how these two things are so related.
Yep, absolutely. Fantastic. So we really covered so much this evening about the female pelvic floor. Clearly, men also have a pelvic floor. They could also have urinary incontinence and fecal incontinence. I want to so thank this expert panel that really demystified, spoke about how common this is, went through really the full gamut of different ways that we test these patients to get to at times a unified diagnosis to make patients feel better about things that they really might have been embarrassed about and were suffering alone. So, with that being said, thank you so much, Dr. Bodner, Dr. Ashok, Dr. Nseo, for your expertise and your time this evening. I want to thank all the attendees for joining us in our webinar, and please join us at our next virtual webinar on the male pelvic floor, urinary, and fecal incontinence. Have a good evening, everyone. Thank you.